Hi, Jean. Hi, Leonie.
Good evening, Dr. Bhana.
I'm good, thank you. Can you, is the PowerPoint showing on your side?
Yes, I have it, but we
So
still got 5 minutes to go.
no, that's fine. I just wanted to know if it's showing. So, um, because on my side, I'm not so confident that it's showing. Is it showing up now?
I can see it perfectly.
Good, and the screen is changing.
Yes, it's changing.
Perfect. Cool. All right. So we're halfway there, and I just want to see. And can you see the pointer moving around?
No,
So you don't see the pointer moving around. Okay.
I don't. I don't know if anyone else can see it.
No, no, no. If you can't, they can't see it. So I'm gonna just change it a little bit. Almost gonna get that right. 1 second. Shit. Hi, good evening, everybody. So it's 7 o'clock. I think we'll just wait 2 more minutes for those who are probably finishing up with supper, and then we'll start. So I hope we can make it interactive. I hope some of you guys got some interesting cases that you can share with us so that we can work through it. So I do have a presentation and just 2 cases today. And hopefully you guys can give me some of your problem cases and we can see if we can work through it together. All right, shall we start? Oh, let's get this going. All right, so today, sorry, did I miss something? All right, so today we're going to be talking about estrogen dominant state. And the first few slides are just going to go through explaining what estrogen dominant state is. We're going to try and go through what estrogen hormones meant to do in the body, what its partner hormones meant to be doing, and then where this excess estrogen comes from. Because, I mean, if you search the medical text, you won't find this term. And yet, today we're dedicating a whole CME to this topic. So, for those of you who don't know me, my name is Bhana. I was the ex-head of endocrinology at Baragwanath Hospital, and now I'm retired. I still lecture, and I'm currently a director and the founder of Center for Advanced Medicine, which is in Waverley. So it's a day clinic, and we run an endocrine practice from there. So my first love is to teach, and so today, let me impose on you on this very interesting field of endocrinology. Today, we're going to mainly deal with female hormones. So the steroid hormone family are all derived from cholesterol. And there are 5 major categories. They are the estrogens, progesterone, androgens, glucocorticoids, and mineralocorticoids. Now, in terms of estrogen, most of us only know estrogen as estradiol. And if you look, there's actually 3 big classes
Dr.
of.
Bhana, the slides aren't changing.
Can you see? So, are you guys still seeing the headline slide?
Yes.
That's not good. All right, let's see if we can move that across. That's a bad start. Okay, I'm going to stop sharing and I'm going to start sharing again. Yeah. Are you guys seeing the screen now?
Yes, we are.
Is it moving now?
Yes, perfect, Dr. Bhana.
Okay, perfect, good. So, I was saying that all steroids are derived from cholesterol, and there's 5 major categories. And in terms of estrogen, most of us only know estradiol. And for those of you who obviously dwelled a bit in endocrinology, you'll know that there's 3 major classes. However, if you take estrogen and you put it through its entire metabolic process, any individual can make up to 24 different metabolites that can come out from estrogen, and most of them are biologically active. And then we'll discuss a bit on progesterone. In terms of androgens, today is not our discussion for androgens, but again, when we speak of androgens, most people uh, go straight to testosterone, but DHA, androstenedione, dihydrotestosterone are all important androgens. We're not going to be discussing mineralocorticoid, and we'll just touch on cortisol. So cholesterol is converted to pregnenolone, which we call the grandmother hormone, and that will further change. Oh, what the hell did I do there? Did it disappear now? Sorry, my screen just disappeared. I don't know. There's gremlins in the system today. Has it come through? Yeah. Okay.
Yes, we can see it.
Okay. And so pregnenolone then gets converted into the in ovaries, in testes, in the adrenal gland to other hormones. And what hormones are made, like I told you, can be very individual. So here's the proof of it. So there's a study, small study, but repeated by many others. 12 subjects were given pregnenolone, and basically the person's urine and blood was then analyzed to look at all the metabolites. And so no two individuals metabolized pregnenolone the same way, and we had different amount of hormones coming through. So when we ask what kind of hormones we're talking about, this is called the Dutch test. And basically, you administer pregnenolone, and then you'll see what it breaks down into. And so you've got androgens, you've got the class of progesterone, and then estrogens. And you'll see the green line shows how much DHA this particular individual made, how much of the DHA converted to androstenedione, and androstenedione then converts to testosterone. And basically, it's like a dial. You can see what the numbers are like. Pregnenolone converts to progesterone, which then breaks down into other molecules. And then we know the androgens can get aromatized to estradiol and estrone, and then that breaks down into further molecules. So all of this happens through various chemical pathways, and so methylation is important, the CYP pathway is important, and glutathione is important as well. So this is an example slide to show you that although we've basically genericized all humans to fit in with what we've been taught at all medical schools, we need to understand that at the end of the day, each one of us has an individual representation of what our hormones are like. And that's why you'll find very few diabetics requiring the same amount of insulin. And even if they do, the response is going to be different. That is why patients with underactive thyroid require individualization. And so more and more in medicine, we find that tailoring treatment is important. So this is the Gaussian curve or the bell-shaped curve, and basically height, color of the eyes, um, race, everything basically will fit in to this curve nicely, whether it's matric exam marks or university entrance marks. Now, we're going to come back to that Gaussian curve in a little bit. So when we all did obstetrics and gynecology in university, this is what we were taught. So basically, they reference it over a 28-day cycle. However, a regular cycle, I mean, if you having a 26-day cycle and it's 26 days every month or 30 days every month, regularity is more important in the field of endocrinology, right? Because these things are all under certain circadian rhythms. Now, what we see is that with estrogen, in the first 14 days of the cycle, the follicular phase, we have very little estrogen, and then it spikes, and you're going to get a second phase coming through into the luteal phase, and then progesterone, which is typically there to match estrogen, to balance it, starts rising towards the second half of the cycle. These are both under the command of LH and FSH, and those are the pituitary commanders. Now, endocrinology is about balance. And whether you look at insulin and its partner hormone glucagon, whether you look at DHA and cortisol, whether it's estrogen and progesterone, we see parsimony operating in biological events that are crucial. And we see this throughout the evolutionary process where the balance between hormones was necessary for growth and reproduction. And you don't see that in some of the other subspecialties. If you look at cardiology, you either got a heart attack or you don't. You either got cardiac failure or you don't. So there either is normality or pathology. And pathology is always on the one extreme. Whereas in endocrinology, too much of any hormone or too little of any hormone is a problem. And it's about balance. And so that's what makes it then interesting. And that's why individualization becomes important. So let's touch on the function of estrogen before we can discuss estrogen dominance. So it's responsible for secondary sexual characteristics. It stimulates growth and multiplication of cells. And it's very important for the regrowth of the uterine lining every month for the majority of a female's reproductive life. And then with time, it's also very important to maintain vaginal and bladder health, because we know in postmenopausal females, once the estrogen levels go down, they start having a bit of atrophy. And so we know its importance as a maintenance hormone as well. Some of its other functions that go beyond fertility and the sexual organs, it's important to decrease bone breakdown. That's why it's an anabolic, and having estrogen on board delays osteopenia and osteoporosis. We know it can decrease thyroid function. We see this when, like in pregnancy, in the perimenopausal state, when the estrogen levels go up, sex hormone binding globulin goes up. It holds onto thyroid hormone, and then free thyroid hormone decreases as well. It has an influence on the mineralocorticoid pathway and prolactin, but also very important for cognitive function. So what are the type of estrogens? So let's start off with the phytoestrogens. Not many of us know that these can be beneficial. They're very weak estrogens, and they're normally used as adaptogens in the East. So whether we're looking at soya or flax or black cohosh, red clover, donquire, and there's quite a few others, these are all considered phytoestrogens. Now, what about some of the human estrogens? So the three big categories: estradiol, this is the primary estrogen. It's the most abundant in the premenopausal female. Its origin is mainly in the ovaries, and very estrogenic hormone, and it's made from aromatization of testosterone. If you recall that first slide where I showed you the building blocks or the metabolic pathway of pregnenolone going into all the other hormones. Then you get estrone. This is the primary estrogenic hormone in the postmenopausal female. And it's made from peripheral conversion of androstenedione in adipose tissue, in liver, and in skin. Some estradiol can also slip into estrogen. Excuse me. And then estriol, it is the weakest of the three, mind the spelling, and basically it's at its highest level in pregnancy. So one wonders why in pregnancy estradiol is at its highest level, when if you look at the pathway, and I'm going to show you that a bit later, that is almost the end breakdown product of estradiol and estrone. And one of the theories is that if estrone and estradiol can be problematic from a cancer perspective, you needed a biological system that's going to be protecting the host from developing cancer or pathology related to excess of these hormones in pregnancy, and that's why estriol is there to neutralize it. But at the moment, it's theory, and it makes for interesting thought. So if you look at these compounds, you'll see that there isn't, most of the structure is the same. All that's changing is what's happening over here. And yet these small changes in the molecule will then determine what happens in the body. So I told you estrone is the one that is predominant postmenopausally. I showed you that it's from aromatization. And so the more obese a person's going to be, of course, the more estrone you're going to end up making as well. High levels are associated with cancer. And then, interestingly enough, some of the synthetic drugs that have been used, that have come onto the market, are mainly estrone. And these two products, obviously they were bought in to the market thinking that it was going to be safe. But now that we know a lot more about estrone, and I'm going to expound on that, some of these companies probably need to rethink about still having some of these products on the market. If you look at estradiol, I told you it's the most potent. High levels are associated with breast cancer and endometrial cancer. So any tissue that is estrogen receptor positive. Mainly premenopausally, mainly produced in the ovaries. That's why it starts going down postmenopausally. And basically, its main function is to replenish the uterine lining for a potential pregnancy. A surge in estradiol is needed from ovulation perspective. And then we're going to come back to ratios. But high estradiol levels compared to estrone will then be beneficial to prevent cancers. Estriol, I told you, is the least potent. Interestingly, it has agonistic and antagonistic properties. And that's why the theories arrived to say, well, if in pregnancy is a state in a female's life where the individual is exposed to the highest level of estrogen they're ever going to be being exposed to, you needed a protective system from its ill effects from a cancer perspective, and yet you needed estradiol for maintaining pregnancy. You needed a protective system, and that's why it's probably got a dual effect. It's very short acting, and when it's a primary metabolite of estrone and estradiol, as I mentioned earlier, and it's the most abundant one found in urine, because of course, once the body's utilized these two, that's the breakdown product. And so it may be protective, and there's some work that has been published showing that it may be protective against breast and endometrial cancers. What about xenoestrogens? So these are endocrine disruptors. Endocrine disruptors is a term that's used where any compound that can mimic, enhance, or decrease the function of a hormone is considered a disruptor. For those of you who don't know it, humans are putting out 2,000 new chemical compounds annually that biological tissues have never experienced before. And so these are byproducts of things that we use commonly: pesticides, solvents, food colorants, plastic, the list goes on. And when they combine, they may even have a synergistic effect. And so xenoestrogens do pose a problem. And then there's, of course, other types of estrogen as well, which may be natural. So if you look at Premarin, the name comes from pregnant mare, which is a female horse, urine. And if you look at a horse's urine, unlike ours or the females with estriol, it is mainly estrone in nature. And so I believe those estrogens were made for horses and ours were made for ours. And of course, along the way, before biology got this expanded, pharmaceutical companies obviously used this over 50 years ago to improve one's symptoms from hot flushes and night sweats. So estriol and estrone can move up and down. I showed you that on the pathway. And then estriol is going to be broken down into 2-hydroxy-estradiol. Estrone can be 2-hydroxy, 16-hydroxy, and 4-hydroxy-estrone. The 2 is protective. The 16-alpha is carcinogenic and a very active estrogen, especially postmenopausally. And the 4 is carcinogenic and very active as well. So the balance between these 3 will then determine risk. And so there's certain things that will influence this pathway. So DIM, a natural compound found in cruciferous vegetables, does increase the production of the protective 1 and of the protective 2-hydroxyestrone and downregulates these guys. And so on this side, you show that DIM upregulates these, which are protective, and downregulates the ones that are not. Hence the term the good, the bad, and the toxic in terms of the 3 different types of estrone, and 2 being the good one, and these not being too good. 3 different studies, just to put it out there, a bit of proof to show you what I've just mentioned. So 1 micromole inhibited the growth of estrogen receptor positive breast cancer cells by 52%. And the compound they used was the 2-hydroxyestrone. That same compound also inhibited in another study the growth of estrogen receptor negative breast cancer cells, which is very interesting. And then exposure of cells to 2-hydroxyestrone caused them to round up and become detached, suggesting that this compound may induce apoptosis. And apoptosis is a good thing in this game. So 3 different studies showing you that in the lab, when you expose these cells to these compounds, we have a reduction in cancer cells. So this then drove the concept of hormone-related cancer prevention by measuring the ratio of the good estrone against the bad one. Now, we can't do that in this country because it's not easy to do the Dutch test. There's the guys at Potch University do it. The medical aids don't pay for it, and it's about 2,200 rand. And so a decrease in the ratio of the 2 and 16 has been associated with an increase in breast cancer and cervical risk. And a decreased ratio means too little of the good one and too much of a bad one. And this, more studies showing the same thing, where a ratio above 2 is different to a ratio below 2 in terms of risk of cancer. So I think let me just leave it there. What's interesting is that Asian women, and you know Asians have a lot of cruciferous vegetables, watercress, nasturtium in their diet. Their ratio of 2 is much higher than 16, and that gives them a protective effect. That's why Asian women, not the current generation, but the generations that passed before that, had the lowest risk of breast cancer. So let's come back to this normal distribution. So whether you take testosterone, whether you take estrogen, whether you take progesterone, whether you take somebody's cholesterol level, pretty much 2.5% of the population will be there. 2.5% of the population will be there. That's the 50th percentile with the mean and median somewhere around there. And so most of us will be distributed there. So in any population, you will always have super females and super males. Now, what do I mean by a superman? So I've got males in the 80s with testosterone levels sitting above 30. The normal reference range for testosterone is 2 to 27. So those men, we can just envy and consider them to be blessed, and we not. Like that, you will in the general population have people with higher estrogen levels than others. So nature planned on this. So where's the problem then? The problem is if you shift this normal graph over to this side, then we're going to have a lot more people that are estrogen dominant. So how is it that nature ends up shifting this curve? Nature doesn't. We end up introducing estrogen into the environment. And so the people that were sitting here within the normal range now are getting excess estrogen coming from outside, and so they are now becoming estrogen dominant. And therein lies the problem of estrogen dominance. So where is this extra estrogen coming from? So let's look at stress. When you have high stress levels, cortisol goes up. Now, cortisol, if you recall, comes from that same pathway that I showed you from the pregnenolone molecule. And when cortisol goes up, progesterone levels are sacrificed. So if progesterone goes down, there's going to be a relative estrogen dominance. Remember, I told you it's about balance. So whether the estrogen is here and the progesterone drops, the body experiences as an imbalance in favor of estrogen dominance. If the progesterone is normal and the estrogen goes up, that is also estrogen dominance. So here, that's how stress works. By pushing cortisol up, progesterone drops. And of course, anovulatory cycles can end up having estrogen, overexposure to estrogen tissues. Iatrogenic, so we cause it. Endocrinologists, gynaes, and those family physicians that are interested in replacing estrogen. So the amount and the type of estrogens we use can influence this. Let us not forget that since the 1950s, there's been an increased use in contraceptive pills. Now, so for those of you who don't know it, every female that's on a contraceptive pill has to pee. That pee has a lot of estrogen that gets into the groundwater and cannot be removed. And so from that perspective, if we're using horses' urine, concentrating it, getting the estrogen out and using it in patients like Premarin, that tells you that every female that's been, who's been on estrogen, is accumulating in the system, and that is why over the last generation male fertility has gone down, because we are over estrogenized and our females are becoming estrogen dominant. So no, sorry, mind the spelling. The spelling is shocking, but that's iatrogenic. So from that perspective, estrogen dominance is worsening and it's not going to change. Now, increasing caloric intake means more fat, and the visceral and subcutaneous fat aromatizes more testosterone to estrogen. We see this in obese males as well. Impaired liver function. Remember, hormones get detoxified in the liver. And a lot of work being done in mitochondria, so I'm not going to touch on that, but ovarian issues can relate to estrogen dominance as well. But by and large, this is the biggest culprit. So it's not normal for a cow to give you milk every day. Humans don't produce milk every day. It's not normal for a chicken to lay an egg every day. I just came back from Boschendal. If none of you have been there, it's a beautiful venue in Cape, worth a check. But they've got the real life free range chickens, and we went to go and see the farm. and they produce about 1,800 to 2,000 eggs a day, and they've got 3,000 chickens. And so they almost laying an egg every day or every second day, and it's not normal for them to do so. So these animals are pumped with hormones to make them feel that they're pregnant, so they continue to produce milk. Now that's coming into the meat and into the byproducts, which means milk, cheese, butter, yogurt. And if I haven't depressed you guys enough, even the vegetarians out there like myself, herbicides, pesticides that are used for your peppers, your tomatoes, and your corn are all xenoestrogens as well. Now, if you're still not convinced, I think I mentioned it at one of my other talks. In the past, endocrinologists used to use this chart to predict a child's future age, height. Those charts can all be thrown away now, and most of you would have noticed that on average, children are becoming taller than their parents because of this excess growth hormone and estrogen and anabolics that are in our foods. So the problem is our normal endogenous estrogen and all hormones and xenoestrogens go through the same pathways for breaking down in the liver. So they all go through this P450, and I'm going to try on the CYP pathways in a little bit, but the end result is that they can influence what's happening to the balance between E1, E2, and E3. So what's the result of this excess estrogen? Early menarche. So over the last 3 or 4 generations, you've seen women used to menstruate between the ages of 15 and 16, and then through the generations, it's gone up. Now people will, young girls will bleed at 9, 10, and 11. So the evolutionary pathway is a slow process. Mutations don't take place so quickly. And so how do we explain that in 1 or 2 generation this has changed? It's all that excess xenoestrogen coming from the environment. And so this also explains irregular and heavy bleeding, breast tenderness. We and gynaes as well have normalized breast tenderness before the cycle. If you go to, I took my kids to the Lesotho village, so you get to see how people lived 100 years ago. They purposefully fed their daughters meat and milk up to the age of 7, and then after the age of 7, they were not allowed to have meat or milk products until they started bleeding. And back then they already knew that if you delay the intake of meat for the young girl, she will menstruate at a later age. And now all of that's been disrupted. And so from that perspective, we've normalized breast tenderness. Breast tenderness is not normal. Whether it's 1 day, 5 days before the cycle, it's a sign of estrogen dominance. There's more depression, fatigue, and concentration with excess estrogen, premenstrual tension in terms of pain, cramps, and mood, decreased libido, water retention. That's why when females get pregnant with the high estrogen levels, you're going to start retaining water. You're going to start putting on weight. That's what estrogen does. And then there's bloating as well. Weight gain, and here it's typically around the hip and the thigh area. And then this excess estrogen is going to promote the growth of fibroids, endometriosis, fibrocystic breast disease. And then if there is a genetic potential for breast cancer, uterine cancers, this will feed it. I don't believe it causes it. I believe it feeds the risk. So estrogen dominance. So remember, the word relative excess is important. Like I said, if the estrogen is here and for whatever reason the progesterones drop, that's estrogen dominance. If the progesterone remains normal, but you've got high estrogens from water, xenoestrogens, or meds, that's also estrogen dominance. And so overdosing, so it's not uncommon that I see in my practice people that have been put on HRT And there's a reason why companies come up with a 25, 37, 50, 75, and 100 microgram patches. There's a reason why the oral HRTs used to be in the 1, 2, and the 4, and they've dispensed off the 4s. So the doses are there for you to dose titrate it to the patient's need. However, there's a lot of overdosing happening. Why? Because people are getting HRT for climateric symptoms, hot flushes, night sweats, vaginal dryness. Now, if you're a female that have been estrogen dominant for a long time, before you went into menopause, remember your body's been exposed to high estrogen level, they've gotten used to high levels. So when it disappears during menopause, these patients are asking you indirectly for more estrogen, and you as physicians are obeying and pushing up the estrogen to get rid of the hot flushes and night sweat, but you're feeding the dominance. And that means all the other issues related to excess estrogen come into play, whether it's weight gain, whether it's fibroadenomatous breast disease, whether it's an increased risk of breast cancer, whether it's a mood issue. So estrogen dominance plays an important role, and we are forced to over estrogenize these patients, and that's where those phytoestrogens work. That's where the phytoestrogens fool the body like Livifem into thinking there's estrogen on board, but there isn't. And that's how you downregulate that. And then, of course, lack of progesterone to balance that estrogen I mentioned will cause that. So these are all the symptoms. I've touched on them already in terms of estrogen dominance. So I asked my PA Leonie to say, be a client. I want you to go and Google, and you can see she's Googled Mayo Foundation, what endometriosis is. So this is what your patient is reading. Endometriosis is a disease in which tissue similar to the lining of the uterus grows outside the uterus. It can cause severe pain in the pelvis, makes it harder to get pregnant. Endometriosis can start at a person's first menstrual period until menopause. So that's what they've been told. And then if you read further on this website, they'll tell you that endometriosis um, can be downregulated by manipulating the hormones. So nowhere does it speak about estrogen excess. It talks about the patient's tissues being more receptive to the estrogen. And guess who we're blaming again now? The patient. So let's look at fibroids. Uterine fibroids are common types of non-cancerous tumors that grow in and on your uterus. Not all fibroids cause symptoms, but when they do, it includes heavy bleeding, back pain, frequent urination, pain on sex. Small fibroids can often be left and don't need treatment. Larger ones may be medicated or surgery. Small ones don't need to be treated. What message are we telling them? You see, you're addressing the end result. You're not working on the cause. And guess what? The cause of fibroids is causing 25 other shit things in the body as well. So you can get many different types of fibroid, but and the same, I'm not going to go through fibroadenoma, but the same thing happens with breast tissue as well. So let's look at some of the role that these guys play in terms of hydroxylation of 2, which is a good one, and 16, which is a bad one. So obesity, increased fat cells, is going to cause a downregulation of 2, doesn't increase 16. Smoking, paradoxically, increases 2, no change there. High protein diet improves the 2-hydroxy. Indole 3-carbinol, another herb extract, is one of the most potent upregulators of 2-hydroxylation. And then exercise increases it as well. So these are just a few things that can improve the metabolism of estrogen. So indole 3-carbinol, it's an extract found in cruciferous vegetables, and supplementations in high concentrations has been shown to promote and upregulate 2-hydroxy forms, which is the protective one. And it's also been shown to reduce activity of the 4-hydroxy enzyme. And so that's also a good thing. So there are ways that we can currently manipulate this. And at this point in time, nothing that modern medicine has that can be used to downregulate the production of 2-hydroxyestrone. Now, remember we implied estrogen dominance, but progesterone is a partner hormone, so it needs to come in somewhere as well. So there is the oldest known sex hormone present in every human cell, regardless of age. The gynaes out there, and I know there's some of you guys today in the audience and obstetrician, progesterone belongs to males and females. They found receptors in almost every part of the human body in both males and females. So it's produced in the ovaries and in the adrenal glands. We know it's been secreted by the corpus luteum to maintain a pregnancy in the first few weeks of implantation. And here, almost every cell in the body has progesterone receptors. And it's also metabolized into other active hormones. And it acts not only on the uterus, but on the breast, on the brain, smooth muscles, kidneys, bone, and other cellular membranes as well. Now, this becomes important in the context where I find some of my clients who've had their uterus removed, gynaes seem to only use estrogen without progesterone, thinking that estrogen was only made there and progesterone was only made for the uterus. If that's the case, then the next time you guys look at blood results, please have a look at progesterone and see that the lab has quoted a number for males for progesterone as well. And if you take a closer look, males have higher progesterone levels for half of the female's month. So if you look at a female's progesterone level during the follicular phase, males have higher levels. Females only beat us on the progesterone level in the second half of the cycle. So the idea that you can use estrogen because alone without a uterus needs to be revisited at medical school all around. Because if there's proof that every cell has the receptor, then there's many other functions that we are missing from not adding progesterone. Besides, we're going against the parsimony of normal biology, where in endocrinology, every hormone has to be balanced. It acts as a natural diuretic, normalizes the potential of blood clotting. So estrogen increases it. Something had to downregulate that, right? Otherwise, you'd end up clotting the placenta during pregnancy and there'll be no child. So you had to have balance. Stimulates osteoblast activity. It's a precursor to other sex steroids. It's a natural antidepressant in most people. I'm not going to touch on it today, but you get progesterone dominant females as well, and that's a completely different problem. Helps normalize thyroid function. Estrogen makes you fat. The right form of progesterone can use fat as a source of energy. It restores libido. It has a protective effect on cholesterol, and it's anti-estrogenic. Now, we know tumor cells multiply very fast. Nowhere do you find a better example in normal physiology where cells grow even faster than cancer cells. And we find this in the uterus, that in 14 to 28 days, you can move a lining from 2 to 3 millimeters right up to 7 to 8 millimeters of tissue. That is behaving like a cancer. And that's what estrogen is meant to do. It's meant to grow and proliferate that lining to get ready for that egg. Now, if that egg is not going to do what it needed to do and there's no implantation, you needed a protective system to get rid of the lining. And if there is implantation, then it is that implantation growing and building a corpus luteum that then's going to produce extra progesterone to keep that estrogen balanced until the placenta kicks in and starts producing progesterone. So human biology is fascinating if you understand the physiology behind it. And so you had to have an anti-estrogenic effect and apoptosis is driven by progesterone. So you had to have that balance. And so I've touched on this already in terms of its importance for ovulation and promoting the ongoing pregnancy. Estrogen causes water retention. This is going to act as a diuretic. I've touched on that. And yeah, and so progesterone inhibits uterine activity, decreasing cramping. So if you've got too much estrogen, too little progesterone, cramping, and there's going to be pain. It has also been shown to downregulate estrogen receptors to create that balance again. It promotes cell differentiation and maturation. And then here it speaks about apoptosis as well. But more importantly, it also induces enzyme for the metabolism of estrogen. Remember I told you estrogen can break down into 24 different compounds? Well, indirectly, it's manipulated by progesterone as well. So what happens when there's progesterone deficiency? Irregular and heavy bleeding, breast tenderness, mood issues, fibrocystic breast tissue, PMS, decreased libido. The net effect of progesterone deficiency will be fibroid growth, endometriosis, water retention and bloating, weight gain, and a higher risk of cancer. Now, before you guys quote the Hearst study to me and the PEPI study for the gynaes amongst you, note that most endocrinologists and gynecologists consider progesterone and progestins to be the same. These are not the same. Why were progestins invented? You need to understand what the business of pharmaceutical companies are there for. They're not there for your benefit or my benefit. They're doing a fantastic job, but they're there in the business of making money. They are listed companies. So if you don't change a natural molecule and make it your own, you cannot get a patent. If you cannot get a patent, you're not going to make money. So I've done over 58 clinical trials in my career at Baragwanath Hospital. And what I've learned is that it takes on average 8 years to come and bring a drug to market. And that's when you're doing fantastically. So from the day you found this molecule till the time you can get it into market, the shortest time period is 8 years. And then you're going to be printing money. Most of them are going to take up to 13 years. And that way they only have 3 or 4 or 5 years to make money. They say that if you invent the cure for death and it comes after the 16th year, you will never make money. That's how this game works. Once you lose patent, that's it. It's game over. And so from a point of view, that's why progesterones were brought into the market. They're synthetic, they're man-made, and they're there to mimic the actions of natural progesterone. Now, the data I presented to you now was not around and was not doable in the lab when these molecules were produced. And so we consider them to be safe because they've been there historically, but they are completely different products. And I'm going to show you that now. So natural progesterone is a molecule that is going to be bioidentical. Natural doesn't always mean safe as well. Bioidentical is safe. Bioidentical means the body recognizes it as self. As opposed to horse urine got estrogen and it's natural, opium is natural, it doesn't have to be safe for the body. So the term bioidentical is what's very important. Now here you'll see what is the side effect profile of progesterone. Slight to moderate drowsiness. Progestin, breast tenderness. And I told you progesterone improves breast tenderness. This guy causes it. Worsens acne, causes bloating. I told you this guy acts as a diuretic. Worsens depression, increases thrombosis. Look at the PEPI study. Migraines and more. So don't believe that progesterone and progesterone are the same molecule. I showed you that estrogen molecules where if you just change a little bit, how the physiology changes. And so you need to understand that if these molecules were invented today, they'd have to be a lot more stringent work done in terms of their pharmacology before they let out. And these products were put out in the market a long time ago. Combination hormonal therapy is very important. And that's why estrogen and progesterone have to be there at balance. Using one without the other, especially when there's no uterus, is dangerous. And estrogen and progesterone have reciprocal actions at a cellular level. They're there for parsimony. Now let's come through to the case studies. So I've just got two. This is a patient who came to me with an estradiol level of around 700. So one may ask, what is normal? So gynaes normally do estrogen progesterone ratios at day 3 and at day 21. But I showed you that these guys don't know day 1 and day 3 and day 14. All hormones are balancing each other out every day. And so although they move in circadian rhythm, that's all taken into account. Yeah. And so from that perspective, nowhere in your cycle except on day of ovulation should the level be that high. So on average, if you look at the median estradiol levels in the follicular phase, it's around 200, and in the luteal phase, it's around 350. And you can have a peak during ovulation. Now it's about balance. One doesn't need to be a doctor to know that you need two numbers for a ratio. So that against 0, any time of the cycle is showing you estrogen dominance. So what did we do for this patient? We added estrogen balance. It's a concoction of some of the products I've spoken about, the DIM, the I3C, calcium deglutarate, which I'm going to chat about in a little bit. And then it's got a lot of phenols, and that is meant to be an adaptogen to help estrogen progesterone receptor activity. And so what happened? Well, the estrogen levels dropped to 150. The problem in this case was the progesterone level didn't go up. So then we added bioidentical progesterone, and pharmaceutical companies make it, compounding pharmacies make it, and I told her to use it every day except when she starts bleeding, and she can stop it for 5 days. And what happened 2 or 3 cycles later? Estradiol level came down, progesterone came up, and it's about the ratio being important. So if you had to do this on day 14, day 24, day 28, it will be more or less have good ratios. And so this is just showing it in another way. You may ask, what the hell was the patient doing by me with estrogen progesterone issues? Well, they had thyroid issues as well and cortisol issues, so I had to work on the other aspects as well. So I showed you that pathway. This is just a cartoon that estrone comes from androstenedione. These can move around between testosterone. Testosterone aromatizes to estradiol. These can move both ways, but that estrone gets metabolized to 2, 4, and 16, the good, the bad, and the very bad. And here, cruciferous vegetables have been shown to increase this pathway and decrease that pathway. And how does it do that? Through working on phase 1, phase 2, and phase 3 detoxification pathways. So most of you have only heard of phase 1 and phase 2. Phase 1, so exogenous hormones, endogenous hormones, environmental disruptors, chemicals, all come into the system. The bowels absorb it and the liver receives it. The liver is a major organ of detoxification. And so when phase 1 gets flooded, there's going to be a problem. Too much, the shower is putting out too much water, it's going to basically overflow. Yeah. So one clue in terms of asking patients whether their phase 1 is working, because I know a lot of people do expensive genetic studies, is very easy. ask them, when they have a glass of wine or gin, do they flush? They have a blocked nose? Do they get a headache? Are they cheap dates? That's already telling you phase one's not working too well. And you'll see people react to coffee as well. I mean, if I go and have a cup of coffee, I'll be in the bathroom 10 times in the next 24 hours. And so that speaks to my detoxification pathways as well. So diet, lifestyle can make a difference, but supplementation with DIM assists, and DIM improves the phase one pathways. Phase two, so once things are in the system, how quickly do they get pushed out? And so that's the water that's already in the bathtub. How are you going to get it out? So that's phase two. And that is driven by the COMT gene, and the methylation pathway is very important. So here the sulforans, I3C, calcium D-glutarate, all very important for phase one and phase two. Generally speaking, NAC, N-acetylcysteine at high doses are very important for liver pathways. And then there's some other natural products as well, lion's mane, kudzo, that have been shown to improve these pathways as well. Quite a bit of work done on alpha lipoic protein as well, and high doses of vitamin E. And then your omegas are important as well. So the ratio between omega-3 and omega-9, which is GLA. So this is where evening primrose oil comes in and works as well, which the gynaes have been using for years. Now, what about phase three? Phase three, we made it up. Phase three is what we now seen what the gut microbiome does to these molecules. We used to think that once it's dumped out, it'll just go in the stool. However, we now know that through glucuronation, this remember I told you that estrone and estradiol breaks down into mainly estriol, and that's the most abundant found in urine. So some of the other hormones can then be brought back into the system because the gut microbiome ends up metabolizing some of the estrogen that's been dumped out into your stool. So before you pass it out, it's been metabolized. So that recirculation pathway can be influenced as well by influencing the gut microbiome, by eating healthier food, by eating more fiber, by cutting down on antibiotics. And that's a talk on its own. And I think we're doing the gut microbiome in December or January, and we'll touch on that. So here it's the indole 3-carbinol in this product. Taking 2 a day will give you 100 milligrams. It's the diindolyl methine, DIM for short, 100 milligrams, and the calcium D-glutarate, 100 milligrams. It's that combination that's going to increase phase one and phase two detoxification pathways. The calcium D-glutarate is strong in working on the phase three pathway. There's methionine. I showed you in the pathway earlier on that glutathione, methionine, the whole MTFR gene plays a very important role here. And then these products that you see here, these herbs, whether it's watercress, cat's claw, or broccoli extract, has been shown to have extremely high levels of phenols, and phenols are important in terms of antioxidants, anti-inflammatory pathways, and some of them have been shown to work on these detoxifying pathways as well. Some polymorphisms that increase breast cancer risk, and these can be done. But if you remember the first pathways I've showed you, the CYP pathway is very important, and that's where the hydroxylation takes place. The CYP B pathways are important. The COM pathway is very important. So all of these are what we're trying to influence by using some of these extracts. To date, we don't have medications, pharmacological medications that are influencing these pathways, and they'll come. Now, remember I spoke about parsimony, the need to balance estrogen and progesterone. So this is a cellular level. That's the DNA. So that's a nucleus. That's the DNA. I always say anything that has a receptor on the cell membrane is important. If you have a receptor with the boss, the DNA, that means it's vitally important for survival. So the sex steroids and vitamin D all have the receptors straight here in the nucleus. And so they must be important, right? And that's why these hormones have what we call physiological quick pathways where they have an immediate effect, and then they have a genomic effect, which takes a lot longer. So a couple of days to a couple of weeks to kick in, whereas the non-genomic effects take place straight away. And so estrogen sits there on the receptor, upregulates proliferation, and that's going to be a problem if there's no brake in the system. Progesterone provides the brake on the system. That's how you balance proliferation with apoptosis. Unopposed estrogen, there's nothing happening here. And so there's a promotion of growth factor, and therein lies the problem. Your maker, the evolutionary pathway, we would have never survived to this point, every species, if estrogen caused breast cancer. You're knocking out the most important out of the two genders, the one that's going to deliver the next generation. How bad would that design be? Where you give the very individual that's going to give you the next generation a hormone that's going to knock them out of breast cancer. And the highest peaks of estrogen are in puberty, pregnancy, and the perimenopausal state. And so, yeah, it didn't make sense. And it's what we've done to the biology that is coming back and biting us. So where's the proof for that? Okay, no, before I give you the proof, let's look at the second case. Okay, sorry, I mixed the slide up. This was the history of that patient. That patient, slide that I showed you, had hypothyroidism, was sexually active, but was not using contraception for the last 3 years. Had weight issues. That was the main complaint to me. And then on further inquiry, she had headaches, anxiety, hair loss, fatigue, PMS, water retention, breast tenderness a week before the cycle, breakouts in the T-zone just before the cycle, and pigmentation issues as well. So sorry, let me go back to that. So that's how she presented. You see, that's why there was the thyroid issue that needed adjustment, but that was causing all of the symptoms. And so you blame the thyroid for the weight, and that minor, when she came to me, it was 3.1, and then she defaulted some treatment, and then she went off and it became worse. But the key thing is an underactive thyroid with a TSH of 3 point something is going to cause 2 or 3 kilos, not 20. Yeah. And so here's another case. So in this particular patient, we had another situation. You can see on the background also thyroid issues as well. But she came to me with an estradiol of 1700. Progesterone very low. And so again, in the follicular phase around 200, luteal phase around 350, luteal phase progesterone around that level, and that's very far from it. So you will never get this in the follicular phase. So it doesn't matter where you did it. It's too high for the follicular, too high for the luteal, and there's no balance over here. Can you see that? And so what we did was, again, we adjusted the thyroid meds. I added thyroid balance for those thyroid antibodies. I think we touched on that the last talk. There was a cortisol problem. It's hidden behind this block over here. And we worked on the cortisol. She was burnt out. So remember what cortisol does? When cortisol goes up, it steals the progesterone. And so progesterone goes down. And so we started estrogen balance and gave her progesterone. And I always start off with a low dose because these things come in 25, 50, 100, 200. They can be compounded. They can be pharmacological, utrogestin, cyclogest. And the end result was over a period of time. It doesn't happen overnight. you can see generally that guy's gone down and that one's gone up. The game's not yet over. We still need to improve that ratio a bit better and get the symptoms right, but you get the drift. So where's my proof that estrogen doesn't cause cancer? Our egos tell us that we're the most important people on the planet at this point in time. Human life has been around for 4.3 billion years. The dinosaurs have been here a lot longer than we have. So if you take a 24-hour clock, in that time period, if that is equated to how long human life's been on the planet, humans make, I think, the last 3 seconds of the 24-hour clock. And so estrogen, progesterone, DHA, cortisol, these pathways have been preserved throughout the animal kingdom. If estrogen caused breast cancer, then the rate would have been constant throughout the generations. And so what we see over a very short 4-generation pathway, and this is data in the USA. There's 2 old universities that have been collecting this data, and you can see that in our great-grandmother's time, the average risk of breast cancer was 1 in 90. The grandmothers then went to 1 in 28. Our mothers 1 in 16. The daughters of those mothers, that means your sisters, for the guys and the women out there listening to the conversation who are the daughters of this current age, 1 in 9, and that's the shit that's going to happen with the next generation. So normality can't change. Some things happen from there to there, and that is the excess estrogen that we've been putting into the environment since we've come up with the contraceptive pill. That's the excess estrogen that has been coming with industrialization and the xenoestrogen with the thousands of compounds, heavy metals we're putting in the environment. And that is what's causing estrogen dominance. And it needs to find its way into our vocabulary, because with each generation, we're seeing more breast cancer, we're seeing more fibroadenomatous tissue, we're seeing more fibroids, and there's more endometriosis. And human physiology doesn't change so quickly. So final effect, I'm not going to harp on it, but there, all the estrogenic effects, there's the balancing act by progesterone. This is not my list. This comes from a physiology medical textbook. And so I'm going to leave it there, and let's open it up for discussion. And please, God, I hope some of you guys, 37 of you that are still online, will have some cases for us. I'm going to just go to the chat. Good evening, please add. Okay, so all of you guys must add your name and your council number so that Leonie can get behind the scenes and get your CPD points. There's obviously a delay, so you don't immediately get it. We have to wait for them to process it, but this is a CPD accredited function, and so are the next 3 or 4. And so some of you guys have been giving me topics that I can share some knowledge with you, and we need to be sharing the knowledge amongst us. So any questions out there? Now, I couldn't have silenced all of you guys. There must be interesting cases in your guys' practice. So I gave you 2 cases where the patients were extremely estrogen dominant. Of course, I had to give you an extreme case, but these are quite subtle. So every one of my patients get interrogated, whether they postmenopausal or not. Even if they're 68, I go back and I tell them, can you remember whether you had breast tenderness, water retention, mood swings before the cycle? How many days was it? Did you ever have fibroids, endometriosis? Because that matters to their future breast cancer risk and fibroadenomatous tissue in the breast and fibroids. So although their risk of endometriosis go down, the risk of the zits go down, pigmentation may still be there, it tells you not only what's going to be important for that particular patient, but what they should be advising their daughters as well, because there is a genetic component to some of these pathways that I've spoken about as well. And so it's a very interesting field. It plagues a lot of our female clients, and I don't think it's well handled. And we've normalized pain before the cycle and breast tenderness before the cycle, and we should actually use it as a sign that there is an issue between the estrogen and progesterone balance in our patients. So I showed you the extreme endocrine estrogen dominance case. I do get patients with normal estrogen levels. So typically they might have estradiol levels of 200, but then you'll see the progesterone will be low. So remember I said, even if the estrogen is normal, but the progesterone is down, that's a relative estrogen dominance, and some people call it progesterone deficiency. Doesn't matter. The receptors still look at it the same way. You could have normal progesterone and too much xenoestrogen, and then you can have both, where you got progestins on board and the xenoestrogens, and that can be problematic as well. So I hope this has helped. Oh, can you use estrogen balance and progesterone cream when you have had an ablation? Okay, good. So if somebody's had a uterine ablation, so for those of you who know what it is, so when a patient's bleeding excessively and becoming iron deficient and you can't get it sorted, one of the options, because in the past they used to just remove the womb, right? So once you've excluded fibroids and polyps and synechiae, some of the other causes of heavy bleeds, then what the gynaes do is basically they ablate the cavity. And once they ablate the cavity and it closes, the patients stop bleeding. So they'll still have their hormones, and sorry, that was a sneeze that didn't come. So they would either stop bleeding completely, or the bleeds would be much lighter, or they will just be spotting. So the question here is, in that patient, can we use estrogen balance? Yeah, remember someone who's had uterine ablation, the estrogen hasn't gone. So the estrogen is still there. It's still acting on the breast. It's still acting elsewhere in the body. There will still be weight issues if there's excess. So estrogen balance is down regulating the estrone, the bad estrogens, but also helping the estrogen progesterone receptor function improve. And then they ask whether you can give progesterone. Yes, you can give progesterone. So irrespective of the ablation, you still need to look at the estrogen progesterone levels and then adjust them. Let me just see if I can catch that question. What are your views on chasteberry to improve progesterone? Yeah. So that's why I said that there are other compounds as well. Remember I spoke about phytoestrogens? Well, there's products that work on progesterone as well. And so from that perspective, chasteberry will help progesterone levels. Of course, if it doesn't, then you need to add it and use the bioidentical one. Does it need to be used at certain times of the cycle? No. I would say if you got a very estrogen dominant person and the progesterone levels are very low, you would want to use it every day and then have a look. And then if the progesterone levels climb and you get better balance, then you can start decreasing the dose, and then you may want to stop it during the bleed. Like I use that progesterone level, and I said just during the bleed, you can stop it. For young women with PMS symptoms, do we prescribe estrogen balance before the menstrual cycle or throughout the cycle? No, they got to take it continuously. So estrogen balance is helping the estrogen conversion to the bad ones 24/7. It's helping balance the receptor function. And then there's work showing how the second messenger pathway systems have been improved as well. And so the detoxification that's happening in the liver is important as well. The dampening of the inflammation with the phenols. So they use it. Estrogen balance is one every day. And then if that works, you carry on. If it's not enough, we go to 2. What I tell my estrogen dominant female patients who are in their 40s and 50s, if they've got daughters and they got breast tenderness, water retention, mood swings, they can start it early so they can behave like the Asian women that were having low risk of fibroids, endometriosis, and breast cancer, because they've been having it in their diet from a very young age. And then also with the ones who have daughters that have started menstruating early as well. I've been asked before, can we use it in young girls before they start bleeding to prevent them from bleeding earlier. I presume you can, but have you seen the size of the tablet? No child is going to be able to put it in. And if you want to get the right doses, that's the size of the tablet. If you want to get 100 milligrams of each of those 3 active compounds, that tablet had to be big, and with methionine and with a bit of NAC. And so you could use it, but I don't think any child's going to be able to swallow that tablet. Are phytoestrogens fine to use if there's a strong family history of breast cancer? So phytoestrogens are weak estrogens, and they're not converting to estrone. And it's the 4-hydroxy and the 16-hydroxyestrone that is the culprit from a breast cancer perspective. Estradiol on its own will also feed a cancer if it's there. So the phytoestrogens, I would say, are fine. But if you're not sure, and remember, the field of genetics is just expanding. And I told you about individualizing treatment. So in the future, already, I mean, there's labs in Pretoria that offer a genetic test that can tell you how you metabolize Panado and rifampicin and antidepressants, and then this one's for you and that one's not for you. And these are very accurate, right? And so genomics is becoming very big. So in the future, we will be able to do a gene test on our patient and then work out exactly what each compound is doing, because you can then see which pathway those compounds are having to work through. And so in this particular case, if you're not sure and there's a strong family history of breast cancer, I would say that patient would have needed a genetic test anyway to ascertain their risk. And number 2, you could do their profile in terms of how they're metabolizing estrogen and see. And so if they're taking the majority of their estrogens and converting it into 4 and 16, I would say no then. Otherwise, if they're not, certainly the phytoestrogens would be fine. What would recommend as an alternative to OPC in young women? Abstinence. Okay, that's a joke. So we're going to be discussing contraceptive pills, I think not on the next one, but the following one. And there's a reason why pharmaceutical companies come up with low dose, medium dose, and high dose. And so you need to able to, on history, work out what the patient's going to need. Typically, all gynaes start off on low dose, and if you're an estrogen dominant female, you're not going to be able to suppress that endogenous estrogen and the xenoestrogens with a low dose, and that means you're adding to the estrogen dominance. And so that's why these patients who are put on sometimes Clara or Years will have spotting and will put on weight, because now you've added to the estrogen. And so there's ways of working it out. So if a young girl is using an oral contraceptive pill as a fertility thing, there's no alternative. You need to either put in a copper T or a Mirena, or use an oral contraceptive pill or condoms. Find a way. The role that oral contraceptives play in terms of estrogen dominance and what it does to progesterone is a different story, and that's what we're going to be discussing. I think 2 CPDs from now. Or what can we use in young people to, okay, same story, right? So typically, excuse me, try and use contraceptive pills that are, none of them are bioidentical, but the most bioidentical. Try and use the ones that have progesterone, that are closer to progesterone than the gestogens on the progestins. And then estrogen balance helps that. And so I then normally combine it with estrogen balance to try and get less breast tenderness, water retention, mood swings, and weight issues. Would using the mini pill microvel postpartum cause an imbalance, and what is a good alternative? So whether the person had a pregnancy or not shouldn't matter in terms of what's going to be used. anyway, whenever you consider using any of these, you got to keep in mind how are you going to be balancing the estrogen and progesterone. So that should be the first consideration. And so if you wanted to use the mini pearl and microveil, that would be fine. Again, typically the female patient just came through a point of estrogen excess pregnancy, and then you're dropping it to ultra low levels, there are going to be issues. Maybe NG wants to tell us what's the point of it. Is it for contraception? Is it to improve a balance? Is it for headaches that they're getting postpartum? Is it because of breast tenderness? I'll need a bit more details in terms of why they're going to be doing that. If it's for contraception, I'll just tell you it's not my favorite contraceptive. But we'll be discussing that, right? Where are we now? Okay. So we'll discuss contraception soon. Any other questions? I think I've kept you guys long enough. It is now 8:20. So I finished 9 minutes earlier than we did last time. It was about an hour and a half. So I've put it out there in the past. You guys can WhatsApp me any interesting cases you've got. It's not about referral. You guys got to get used to managing these patients, build up the confidence. So I'm happy to take WhatsApp messages, and then when I'm free in between the day or towards the end of the day, I'll happily reply. Some of you guys have been doing that, putting your patients' short cases on or results, and I always like to assist. Not because I'm nice, it's because I find I like challenging cases. So it's more for my own altruistic purposes. It keeps the brain ticking. So thank you very much. I hope this was helpful. And if it was, we'll see you guys in the future ones. If it's not, maybe suggest how we can change it. And we've put the topics out there before time, and you guys all have Leonie's details. So don't be shy to send the cases. If you know we're going to be dealing with insulin resistance and type 2 diabetes next time, you send your case. So then that way, they're your real cases. Yeah. And so these issues with the mini pearl and microveil, if you've got real life cases, just put a short history, 1 or 2 results, send it out to Leonie, and then it's better for me to discuss your cases than my cases alone. Okay. So good evening, and thank you guys for attending, and Leonie will attend to your CPD certificates. Good night.